So, good evening, everyone. My name is Dr. Sailesh Gupta. I'm a consultant in Department of Minimal Access Pediatric and Robotic Surgery for Max Pepperganj and Vaishali. So, today I'm going to talk on gallbladder malignancy and its management. So, it is a very important topic, and it can come into your theory examination and can also be present like a GB lump in your long case, and long case can make you fail or pass. So it is one of the most important topic, and gallbladder malignancy will always come. If anything, viva goes on gallbladder stones or anything, gallbladder malignancy can also be asked. And it is one of the most common pathology we see in northern part of India. So starting with gallbladder cancer is a rare malignancy, but represent almost 50% of all biliary tract cancers. So biliary cancers are highly fatal malignancies with a 5-year survival rate of 17.6%, which is very poor. And the prognosis is poor due to aggressive tumor biology, late presentation, complicated anatomical position, and advanced stage of diagnosis. So in this slide, 2 points are important. It is rare, but most common of the biliary tract cancer. Second thing, prognosis is poor and as the late presentation. So locally advanced and metastatic disease is treated with palliative chemotherapy, but early stage is potentially curative with surgical resection followed by adjuvant therapy. So it shows the importance of early diagnosis. So what is etiology? So chronic inflammation is the most critical risk of gallbladder cancer. And the most common cause of chronic inflammation is gallstone, which is cholelithiasis. And the risk of CAGB increases with the gallstone size, chronicity, and burden of symptoms. Porcine gallbladder is a very common term. Is a basically calcified gallbladder, which is commonly found incidentally on CT scan, and it is due to the chronic cholelithiasis. And this is a quite a risk factor for CAGB. Other risk factors are gallbladder polyp, congenital biliary cyst, and abnormal pancreatobiliary anatomy. All these things can lead to chronic inflammation. So, cholelithiasis, porcine gallbladder, gallbladder polyp, congenital biliary cyst, and abnormal pancreatobiliary anatomy. And it is also important to know that the gallstone size also correlate with the chances of the CAGB, and number of polyp and size of polyp are also a risk factor of the CAGB. Now coming on to the other risk factors or etiology, chronic carrier of Salmonella and Heliobacter also have been associated with the increased chances of gallbladder cancers. Carcinogens like methyl dopa, isoniazide, methyl cellulose, radon, cigarette smoking are also a risk factor. And chronic primary sclerosing cholangitis and inflammatory bowel disease can also lead to gallbladder cancer. So PAC and IBDs are also common cause, carcinogen and Salmonella typhi. So what is epidemiology? The incidence of gallbladder cancer is high in South America, India, Pakistan, Japan, and Korea due to high prevalence of gallstone and chronic gallbladder infection in those areas. Gallbladder cancer is more common in white, Southwestern Native American, and Mexican Americans, and less common in African Americans. So what is the pathophysiology? What is the pathology which causes this? The current hypothesis, as I have told earlier, established that chronic inflammation of the bile duct accumulates successive genomic mutations that lead to malignant transformation. So the most common mutation is oncogene KRAS and tumor suppressor gene beta-catenin. So both these mutations are the common cause of CAGB. As such, there is no hereditary family risk has been found out. So inflammation is a cause. Inflammation leads to genomic mutation. Mutation common in oncogene KRAS and tumor suppressor beta-catenin leads to CAGB. So what is the most common pathological picture? Most common pathological picture is adenocarcinoma. The condition progressed from the pre-neoplastic to carcinoma in situ and ultimately to invasive carcinoma following roughly 15 years of inflammation. So that is why it says that if you have a stone, immediately there is a lesser risk, but down the line, as the time progress, chances of carcinoma increases. Squamous cell carcinoma is rare in the gallbladder. So adenocarcinoma is the most common. So now, as a part of clinician, it is very important us to know the clinical signs so that we can detect it. Gallbladder cancer detection often occur as an incidental finding on imaging or after a surgical process. It is very important. Most we are a surgeon, we most of the time we find the carcinoma in situ T1 and T1B stage in the pathological report, as the patient didn't had any sign, right? Early stage cancer is commonly discovered after cholecystectomy and review of the surgical pathology specimen. CAGB patients are often asymptomatic at presentation describe vague symptoms such as abdominal pain, nausea, vomiting, indigestion, weakness, anorexia, loss of appetite, weight loss, and can present with jaundice, which can be easily confused with the cholecystitis. So you need to understand that most commonly they're asymptomatic. Pain, nausea, vomiting, indigestion, weakness are very non-specific signs, GI signs. So there's no specific symptoms. Basically, jaundice happen at very late stage, at the stage where the mass is compressing the CBD, mass is spread to the lymph node, which is compressing the porta, which is compressing at porta. So it present late, and most often they are discovered after in a surgical pathological specimen of cholecystectomy. So in the later stage, biliary obstruction by CAGB lead to jaundice, clay colored stool, cola colored urine, and skin pruritus, which is a feature of basically obstructive jaundice. Mirzi syndromes, which caused by the impacted stone or a mass of GB compressing the CBD or CHD, is associated with the poor prognosis because it shows that the malignancy is spread further. Other non-specific symptoms are weight loss and general malaise, which can be there with any malignancies. So now we have discussed about the clinical features. So what do we find on examination? So jaundice, right upper quadrant pain could be there. Jaundice obviously would be there in a later stage. Kursovere sign, very, very important. These three lines are, which can be asked in Viva or in a theory exam. Basically, non-tender palpable gallbladder with jaundice will be there in CAGB, which is most likely due to the chronic progressive malignant obstruction rather than an intermittent gallstone obstruction. It is important to know that in the case of gallstone, there is a multiple episode of inflammation. So gallstone get contracted. So you're never going to find a lump. But in case of a CAGB, because of a mass, because of a cancer, you will going to feel a gallbladder. So in a CAGB, they will be jaundice with a palpable gallbladder, non-tender gallbladder. But in case of cholecystitis, because of choledocholithiasis, they could be jaundice, but gallbladder will not be palpable. And hepatomegaly, abdominal palpable mass, ascites, and bowel obstruction on physical examination are presentation that indicates the advanced metastatic disease. So this means that the disease has spread to the peritoneum. There is a multiple liver metastatic liver mass, liver tumors are there. Disease has spread out. So now we have discussed about the like the clinical features, and now how you're going to evaluate it. So the most common initial investigation you're going to do is CBC and LFTs, which in case of progressive disease might show the biliary obstruction pattern. Ultrasound and CT are the usually initial imaging findings. Endoscopic ultrasound is more accurate than ultrasound because it is important to know that in every GI malignancy, endoscopic ultrasound is better because it tells us about the depth of invasion. For T staging or N staging, endoscopic ultrasound is better than CT and ultrasound because it tells us about the invasion. It tells us about the T stage because in endoscopic ultrasound, the lining of the various layers of the organs are better delineated as compared to CT scan. So it is more accurate, 76%. and it provide more valuable tumor stage description with invasion depth and local lymphadenopathy. Now coming on to the CT and MRI. CT's limitation in discriminating the benign from malignant, but dynamic MRI and MRCP can help assess the disease extent more accurately and properly identify the unresectable candidate with hepatodental ligament invasion, vascular encasement, and or lymph node involvement. Most CAGBs are FDG avid, therefore they can be detected on the PET-CT scan better. So this PET-CT scan can identify the distant metastasis, which avoids unnecessary surgery. So tumor markers are also useful in evaluation. Marker as CEA and CA 99.9 are frequently elevated but not considered non-diagnostic, are considered non-diagnostic because they have a less specificity and sensitivity. So CEA and C19.9 baseline tests are useful for monitoring response to therapy also, right? So they can be used, but they are not much accurate, and their main importance come out to check the response of the therapy. So, so the preferred staging is TNM staging given by the American Joint Committee of Cancer. It grades the cancer from grade 0 to grade 4, and there is also it tells about the survival, which decreases as the stage progresses.